Thank you, Nasir. That was a very clear run through abnormal liver biochemistry. So we're going to move on now to our next speaker in this session, who is Dr. Preya Patel. She's a transplant hepatologist from the Freeman Hospital in Newcastle, and she's going to talk to us about non-alcoholic fatty liver disease. Cheers. Thanks, Preya.
So I've been asked to talk to you about non-alcoholic fatty liver disease. So I guess the first thing to ask is, why is it important? And I know this graph's done the rounds a lot, but what it's showing us is that since the 1970s, there's been a 400-fold increase in deaths attributed to chronic liver disease. It's the third leading cause of death in England. In those aged 35 to 49, it's actually the leading cause of death. What's even more concerning is when you break it down, 90% of those could be preventable due to obesity, alcohol misuse, viral hepatitis. But 75% of those patients present at a point where they've already got cirrhosis. So our opportunities to intervene, put in lifestyle management, and change the trajectory of their disease has already disappeared. Non-alcoholic fatty liver disease is actually the leading cause of chronic liver disease worldwide, and it's increasing in prevalence alongside with obesity and type 2 diabetes. So what is NAFLD? Well, basically, it's an increase in hepatic fat accumulation with metabolic risk factors when you've excluded other causes. As you can see here, it's a trajectory. It ranges from simple steatosis, inflammation in the hepatocytes where you get steatohepatitis. It can lead on to causing cirrhosis, at which point these patients become at risk of developing the consequence of that, such as hepatocellular carcinoma, decompensation. It affects up to 30% of the general population, so this is something you're going to be seeing in primary care. But when you look at those patients who are obese or diabetic, that prevalence increases up to 70%. So who do you suspect NAFLD in? Well, unsurprisingly, anyone who's overweight, obese, and that can be up to 50% of the population. In England, 2/3 of the general population are actually obese, so it is a really big burden that we need to think about. It's important to think about those who are older, sedentary, those who are type 2 diabetics. But really what we need to be doing is looking for NAFLD in those high-risk areas, so anybody with the metabolic syndrome. The other thing to think about are those patients who've developed consequences of obesity, such as those with sleep apnea, people who are at bigger risk of it, so they're on drugs that are going to contribute and make this worse, such as methotrexate or steroids, so patients with psoriasis or rheumatoid arthritis. Historically, we've gone for a pragmatic diagnosis of NAFLD, and that's relied on looking at abnormal LFTs with imaging that suggests fatty liver disease, imaging that shows steatosis, or a combination of mildly abnormal LFTs and risk factors for metabolic disease. And we've then excluded other causes, such as alcohol, viral hepatitis, hepatotoxic drugs. And the reason it's important to know about whether or not these patients have got additional risk factors is if you've got one reason for having liver disease, that's bad enough. If you've got two, the risk increases, and these patients are much more likely to have a more advanced disease etiology and prognosis. But what's really important, I think, is when you think about NAFLD, what about the liver enzymes? So Nasir sort of touched on this a little bit. So the traditional abnormality, I'm not sure how well that's projecting, is most people with NAFLD have a very mildly raised gamma GT. Typically, you may see a raised ALT and a gamma GT, but 80% of patients who've got NAFLD have normal liver function tests, and so they're not really the best way for us to identify this cohort of patients. In addition to this, the more advanced liver disease you've got, your ALT tends to fall. The older you get, your ALT tends to fall. So unsurprisingly, people who've got advanced liver disease tend to have really normal LFTs, and it's not the way we're picking them up. People with fatty liver disease also tend to have a very mildly raised IgA, similar to what happens with alcohol, and as Nasir said, they tend to have a raised ferritin as well. So there are other clues that may pick it up. So really what we should be doing, as opposed to relying on seeing an abnormal test and reacting, is thinking about who's at risk and trying to identify them. And when we talk about identifying them, we also mean staging. And staging to a hepatologist really means Does this person have advanced fibrosis or not? Are there things that they need to be referred to secondary care for? The reason it's important, particularly in NAFLD, is fibrosis is the key prognostic marker. So this Kaplan-Meier curve that I've put up really looks at patients who have got fibrosis and NASH and looks at their survival over 20 years. So those patients who are on the red and the green lines are patients that have got fibrosis, whether or not they've got NASH. And as you can see, they're the ones that have poor survival. Patients who've got F4 fibrosis, so cirrhotic, are the ones that are much more likely to develop liver-related complications such as decompensation, HCC. They're also much more likely to have a higher mortality than those patients with F3 or below. So how do we stage them? Now, it's not realistic, is it, to think about biopsying all these patients, but that's been the gold standard up until now. But it's invasive, it's not without risk. It requires at least a day case hospital stay, a trained operator, a histopathologist, and it's a long turnaround. So we've developed non-invasive tests. There are three real sort of groups of this. The first are those that are blood-based tests, so the simple ones that you can calculate, so a FIB4 or a NAFLD fibrosis score. You've then got the composite biomarkers, so commercially available biomarkers that you can get, and the most commonly used in the UK is the ELF test. And then you've got imaging techniques, such as elastography, and again, the most commonly known or recognized is a FibroScan. So if we go through these, so the first line staging is the simple ones, so using either a FIB4 or a NAFLD fibrosis score. Now, these are really simple things that you can do. They're free online, there are apps you can download. I know some practices that have actually managed to get their electronic record to automatically calculate this. They use information that should hopefully be available in the patient's record. So for the FIB4, that's age, AST, ALT, and a platelet count. The NAFLD fibrosis score requires a bit more information. You need to tell the calculator the patient's BMI, whether or not they're diabetic, as well as their albumin. The benefit of these, they're simple, they're quick, they're low to no additional cost, they're repetitive, and even better, they've got a 94% negative predictive value. So if they're negative, they're really good at ruling out advanced fibrosis. But they're not great at identifying people who definitely do have advanced fibrosis. So that's where the next line of tests come in. One of the ways to use it, so this is the pathway we use at the Newcastle Trust, is people that you suspect NAFLD. Now, the important thing to know about the FIB4 is it hasn't been validated in patients under the age of 35. So if they're younger than 35 and you're suspecting NAFLD, you need to use a different test to check their fibrosis status, be that an ELF, be that FibroScan. If they're between 36 to 65, you check their FIB4. If it's less than 1.3, great. They've got really high negative predictive value, there's no evidence of advanced fibrosis, they do not currently need to be referred in. But what we do need to do is identify that as a point at which we can intervene, start lifestyle management, and give them some good advice, and I'll touch on that in a bit later. If their score's above 1.3, they either need a second line test or they need referral in to hepatology. For those above the age of 65, the cutoff for FIB4 is actually 2. So if their score is less than 2, same thing again. They do not have advanced disease. They do not need to be referred in at the moment. But anything above that, they need to either have a second line test or they need to be referred in. So the ELF test is the commonest in the UK. It's a commercially available biomarker. It is calculated based off a logarithmic algorithm based off 3 hepatic fibrosis products, basically, which is a combination of hyaluronic acid, tissue metalloproteinase, and collagen 3,3. They all get together and they give you an ELF score. There's no units to this, but basically, the higher the score, the more likely you've got fibrosis. It's been used in 2 ways. So a score less than 7.7 has got a really high negative predictive value of ruling out advanced fibrosis. So again, these patients do not need to be referred in. If the score is greater than 9.8, it's got a really high positive predictive value, and this patient's much more likely to have advanced liver disease and probably does need to be referred in. The next sort of test you've got is transient elastography. So this is an imaging-based test. It's basically very similar to an ultrasound. The patient lies down, they have an ultrasound test given, a pulse is sent through, which uses a mathematical formula to calculate a shear wave, which gives you a marker of this person's elastography and how stiff their liver is. Again, the same sort of theory. Bigger the number, stiffer the liver, more advanced more likely they're going to have advanced liver disease. The benefits of this, again, it's easily reproducible, it's easily doable. The negatives, it requires a trained operator, it requires the machine, and it is repetitive, but that is a cost to itself. So how do you take all of these three things and put them together into a risk stratification pathway, particularly in primary care? So I'm going to talk you through two pathways that I know are currently in use, utilising either the ELF or the FibroScan, and hopefully I'll give you some guidance. So up in Newcastle, anyone that you suspect that has got NAFLD, if they're overweight, if they're diabetic or metabolic syndrome, we suggest people calculate the FIB4. The main reason for that is it's easier to do. You do not need to have the patient in front of you to calculate their BMI, and it's something that you can do just off the electronic record. If their scores are low risk, so less than 1.3 if they're under 65, or less than 2 if they are over 65, they're deemed low risk. They can be stay in primary care, we advise lifestyle advice, and we advise treating their metabolic risk, but these scores need to be repeated because everything progresses, so we would advise a repeat score in 3 years' time. If the scores are raised, so indeterminate, we suggest a second-line test, and we advise transient elastography, so a FibroScan. In our hospital trust, unfortunately, FibroScan's only available via the hospitals, but I know throughout the country some of this is available as direct access to GPs. So for NAFLD, if their FibroScan is less than 8, again, we would deem that low risk. That can stay in primary care. If their FibroScan is above 8, that means they need further assessment, and that may mean the need for a liver biopsy to determine where in that disease trajectory they are. So they may be F0 at that point, in which case they can be discharged again with clear guidelines about what timing they need to be referred back for reassessment. If they're F2 to 3, we'd probably keep them under clinic for a period of time to see if they would meet clinical trial requirements, or there may be NAFLD therapy we can prescribe. If they're F4, they're cirrhotic, and they need to be managed as a cirrhotic, particularly to look for their signs and symptoms of decompensation. In London, in Camden and Islington, they've set up a slightly different liver pathway, and they've utilised the ELF test. So very similarly, they've started off with patients who are at risk of having NAFLD, having a FIB4 score. If their FIB4 is low, these patients are deemed low risk. They stay in primary care. They've used a high cutoff for the FIB4 of 3.25, and they've used that to predict a risk of advanced fibrosis, and those patients should automatically be referred to secondary care. For those that are indeterminate, for a score of 1.3 to 3.25, they've suggested an ELF test. And if the score is less than 9.5, they've said discharge primary care, repeat the FIB4 and the ELF in 3 years' time. If the score was raised, 9.5, they suggest referral to hepatology. Now, for some of you that have used the ELF test, you may be aware that these numbers seem to be a little bit strange, and we're picking different numbers out of everywhere. So NICE has approved the ELF test, but NICE has approved it with a score of 10.51 as a positive predictive value of advanced fibrosis. Should definitely go to secondary care. The actual manufacturers have suggested an ELF score cutoff of 9.8, and the discrepancy there really lies between, I think the 10.51 came from the paediatric cohort. In adults, the majority of papers that have been published say a score of greater than 9.8 has a high risk of severe fibrosis, so F3 or above, and therefore should be referred to secondary care. The FIB4 cutoffs on this slide are different as well. So in NAFLD, normally a FIB4 of greater than 2.67 is deemed high risk. They've used a higher cutoff because they used it as a direct test to referral as opposed to using a second-line test after it. So I've told you how to stage them, I've told you how to find them. What do you do with them? Well, unfortunately, at the moment, we don't have specific treatment that's going to cure or reverse NAFLD. The mainstay of management really is lifestyle modification. I think the important takeaway message from this is patients with NAFLD don't tend to die related to liver complications. It's actually their cardiovascular risk that they're most at risk from, and it's really important to try and optimize that as best as possible with optimizing glycemic control, optimizing their cardiovascular risk factors. So if they need a statin, even if their LFTs are mildly abnormal, please start one. We would advise weight loss, and we do say aim for a weight loss of 5 to 10%. So we are not expecting someone with a BMI of 40 to get down to a BMI of 23, but 5 to 10% of their weight is achievable. And the reason we're saying that, for those people that manage 10% of weight loss, 50% of them have had fibrosis regression on further studies. So if they can do it, they can definitely halt progression, and then sometimes might even be able to reverse their disease trajectory. If they're candidates for weight loss adjuncts such as orlistat, then please put them on them. Advising exercise, so any exercise, even if they don't manage to lose weight, has got really good cardiovascular benefits. And what I would say to patients is if you can lose even 1 to 2 kilos, actually that's been associated with reducing your fat load on imaging, so that's going to be beneficial. Coffee's an interesting one as well. So studies have actually shown that if you tell patients to drink at least 2 cups of coffee a day, some studies have shown that's nearly halved their risk of developing cirrhosis, and quite a lot of patients are quite amenable to trying this. I think it's a no-brainer. It's not going to do them any harm. If they want to try it and it's going to reduce their risk, why not? So to go through that, basically, anyone who's got NAFLD, please talk to them about weight loss and give them a set target. If they have access to dietetics or exercise advice, please put them forward to that. If they're a candidate for weight loss adjuncts or bariatric surgery, they should be referred for that. But the most important thing is to manage their cardiovascular risk. Patients with no to mild fibrosis can stay in primary care, but they need to be reassessed every 3 years. Patients who've got significant fibrosis or advanced fibrosis should be managed in secondary care, and we should be thinking about whether or not there are things we can optimize. So for the diabetics, ensuring if they are on GLP-1s or SGLT2 inhibitors, those are the things forward, looking to see if there are new clinical trials coming through. For those that are cirrhotic, they need to be told they're cirrhotic and they need to be managed as cirrhotic. So HCC surveillance, varicose surveillance, and making sure they're getting regular DEXAs and monitoring them for signs of decompensation. So practical tips. I think I'd tell patients what NAFLD is. It's really common, but actually, if they can institute simple changes in their lifestyle, it is reversible. Setting an achievable weight loss target. Sometimes patients we say weight loss to, and they're expecting the unimaginable. But if we actually break it down for them and say, you weigh this much, I want you to lose this, which could equate to half a stone, a lot of them are actually a lot more amenable to trying to do that. Simple dietary interventions, regular meal patterns, portion control. I think most of us have forgotten what a real portion should be because we've never had to restrict it. And I think sitting there and talking to patients about it and making it more relatable, they do really take it on board. Self-regulation, so calorie counters or, motivating apps that monitor your activity can get patients moving. If there are exercise schemes, community gyms, signposting them to them, weight management programs, making them realize they're not alone in this is quite common. And I think assessing readiness to change. I think we've all had those patients that really don't want to hear it and aren't there yet. But those that are, if we can make a difference on them and just repeating that brief intervention whenever you do get to see them, hopefully will make a difference slowly. Thank you.